Instead, we're going to hear from Dr. Anita Sanan, who is the medical director of EntheoMed's Ketamine Clinic, which has just started here in Kelowna. She's going to be giving an overview of ketamine and its uses.
Good. I'll just lower your expectations. I'm not going to walk across the stage in these heels, so I'll just stay put. So I'm Dr. Anita Sanan. I'm the medical director of the EntheoMed Ketamine Suite. I'm an anesthesiologist at Kelowna General Hospital. I've been practicing there since 2010, and I'm also a clinical instructor at the UBC School of Medicine. So a little bit about how I got started in this whole ketamine realm. It's not like I was looking for another job, because I already have a few. But I had a little interest in my mind about ketamine about 4 or 5 years ago. As anesthesiologists, we're highly involved in ECT therapy in the hospital, and if you've ever been witnessed an ECT or been part of it, you can understand how difficult that is to be a part of. It's very resource intensive, it's difficult on patients, it's difficult from a standpoint of needing nursing. All the patients need general anesthetics, they all need post-operative recovery care, and they also all have usually some profound side effects secondary to that. And we've been doing, when you tell people we still do ECTs, they're often in shock because they can't believe that we have not progressed past doing ECT. And so I thought that there had to be some other alternatives and some other solutions. And obviously in the US, there have been multiple ketamine clinics that have arisen. And so I piqued my interest into ketamine. And then I actually met these good folks fortuitously, and we all kind of fell into the same pail together with the same common interest. And so we brought this together. So what is ketamine? So I'm going to talk mostly about the medical aspects of ketamine. I'll leave all the psychiatry stuff to someone who is much smarter than I am in that aspect. But I will preface by saying that we're all not naive here. We know that ketamine is not a magic cure or magic bullet or a panacea that's going to suddenly magically cure everyone's depression. That's not a realistic expectation. What we're looking at is to modify people's disease process so that they can actually have alternatives to what the traditional medications or traditional approaches to depression are, and hopefully have some functional lifestyle changes according to that. So that's the goal here. We all agree that it's not that this is going to be some magic bullet that's going to cure everyone's depression. So what do people think ketamine is? If you talk to common people, lay people, what do they believe that ketamine is? Well, everyone's heard about it as a horse tranquilizer. It's used in veterinary medicine. They think of it as a hallucinogen, a party drug, so they know about Special K, they know about the K-hole, they know about inducing psychosis, and people are also concerned that ketamine is highly addictive and it's very likely to be abused. So some of these things are true. Ketamine is a veterinary medicine. It is a tranquilizer. It does cause hallucinations. It is a psychedelic. It is abused by some people, but under medical supervision, that's very unlikely. There's very low risk of addiction capabilities with ketamine, especially in a medically supervised setting. We'll talk a little bit about the history of ketamine. So ketamine is a phencyclidine derivative, so PCP, which people know about as a common hallucinogen. It was first developed by chemists at Parker Davis in the early 50s, and then they ran some studies. They tried to use it in humans and found that they had severe emergence delirium that was very difficult to control, and so it was abandoned for use in humans after that. But of course, there was still interest in developing something else that might be useful, and so they synthesized ketamine in 1962 by Calvin Stevens. And the first human anesthetic was given with ketamine in 1964. So this has been a drug that's been around for a long time. The first human trials were actually published in 1966. And it was approved for human use in the 1970s. So the FDA has approved ketamine since the 70s. It's been approved for as an anesthetic. And of course, we are using it as an off-label medication. The majority of medications that are used these days are actually used in an off-label medication. So this is not wavering into a gray zone or anything. It's also on the list of WHO's essential medications. The reason we're focusing on ketamine is a number of reasons. So one is that ketamine is the only legally available psychedelic currently. Obviously, the government regulations may change in the future, but currently this is the only one that's available to us. Secondly, the evidence to support ketamine, or for treatment-resistant depression in general, the evidence for ketamine is the most robust. So this has the most studies behind it, has the most published papers. Ketamine has the most evidence to support its use out of all the psychedelics. So we're going to go very briefly over the pharmacology of ketamine because most of you are not anesthesiologists and probably have no interest in the pharmacology to some degree. But it is a racemic mixture, which means mirror images two enantiomers together are two mirror images of the same molecule. So there's two different types of ketamine. There's S-ketamine and R-ketamine. And what we get is a racemic mixture of both. There is S-ketamine, which is available as its own derivative, and that's usually available in the intranasal form. There is some investigative work being done into trying to isolate the different types of ketamine. Some theories that some parts of ketamine or some non-mixtures or more pure forms of ketamine may have fewer side effects, but that hasn't actually played out in the studies so far. So how does ketamine work? How does ketamine work in general, and then how does ketamine work for depression is what we're going to talk about. So in terms of depression, nobody actually knows exactly how ketamine works for depression. There is no obvious mechanism of action, but there are obviously theories. So this is what we think, or what the general consensus is among the scientific world of how ketamine works for depression. So ketamine is an NMDA receptor antagonist, which is a calcium-gated ion channel. And basically, what happens is when ketamine acts at the receptor, it's an antagonist, and that increases the amount of glutamate, or a glutamate surge is produced at the synapse. So glutamate is one of the most prevalent excitatory neurotransmitters in the neuronal synapse. GABA is one of the other ones. And so when that surge happens, you get an increase in excitatory neurotransmission, you get increase in synapses, you get increase in neuroconnectivity. And so that's the theory of how this improves depression. The theory is that people with depression or major depressive disorder have lower levels of glutamate. So what's interesting here is that things like SSRIs and SNRIs work on the MAOI receptors. And those neurotransmitters account for about 20% of the neurotransmitters in the brain. So the theory is that actually the reason that SSRIs and SNRIs maybe are not as effective is because we're only targeting such a small amount of neurotransmitter in the brain. So it may explain why it takes so long for SSRIs to work and why they may not be as effective as ketamine can be. Ketamine has a number of pleiotropic effects, meaning it acts at multiple receptors. So it works at opioid receptors, MAOI receptors, as well as acetylcholine receptors, and at the NMDA receptor. So what are the clinical actions of ketamine? So ketamine is an anesthesia agent, so meaning it induces dissociative anesthesia. I use ketamine daily in my practice. I use it in pediatrics, in adult medicine. Ketamine is used effectively in war-torn areas because it's a very effective anesthetic with minimal side effects. So it has been used in remote areas, third world medicine, war-torn areas. It works well in trauma in patients who are septic, who have shock states, for a number of reasons because it is quite stable. It acts as an analgesic, so it does act on opioid receptors. It works in chronic pain. It works very well in acute pain. Dr. Luo had put up a study there from both the Cochrane Review and others that showed how using ketamine has profound opioid-sparing effects in both acute pain postoperatively as well as in chronic pain disorders. And is also can be used, or we'll show some studies that show that there might be some effect in patients who have chronic opioid use disorder as well. In terms of the antidepressant effect with opioid receptors, so there was theories that the antidepressant effect occurs because ketamine hits opioid receptors, but patients actually given naloxone, which is an antagonist of the opioid receptor, still had antidepressant effects from the ketamine. Ketamine is also an anti-inflammatory, so this is another theory as to how it works for depression, because we know that chronic stress and depression causes inflammation in the brain. That inflammation in the brain does cause neuronal atrophy and reduces neuronal connectivity, so it may perhaps work that way as well. And then we know that it's an antidepressant. So with regards to ketamine as an antidepressant, about 7 out of 10 patients with treatment-resistant depression will respond to ketamine. So that's a pretty profound number, and that's consistent in the studies to show that effect is there very early on. So ketamine has a profound anti-suicidality effect as well. So patients who are acutely suicidal do respond to ketamine with a reduction in suicidality as well. So the pharmacokinetics, meaning what does this drug do in our body? again, more boring stuff, but we'll go through it relatively quickly. So the benefits of ketamine are that it has a very rapid onset. Obviously, it depends on the route of administration because it's varying absorbability. And then it's distributed very quickly to the highly perfused tissue, which is the brain, the heart, and the lungs. So once it enters your system, the alpha half-life, meaning when it gets dispersed to these high vascular tissues, is about 15 minutes, and the elimination half-life is only 2 to 3 hours. So most drugs go through 5 elimination half-lives before they're out of your system, so you can see that it's a relatively short period of time that ketamine actually stays in your system. Ketamine does get metabolized by cytochrome P450 in the liver, and there are multiple active metabolites. And now there's a question as to whether it's the metabolites actually that cause the effects of ketamine versus whether the ketamine itself is what's causing it effects. It is renally excreted. And so this little chart just shows you the difference on the routes of administration. So there's some interesting things to point out to here. You can see that IV is obviously 100% bioavailable and onset is immediate, but IM is a pretty close second. So it's 93% bioavailable. Onset time is a little bit slower and the duration of action is a little bit longer. The peak effect takes a bit more time, obviously. What's interesting to me is that intranasal is kind of what the government has got behind in the S-ketamine, but the bioavailability is so variable. So it depends on a number of things. Nasal mucosas are not the same in every person. And it's also user error. So depending on how people administer it to themselves, they may or may not get the dose that they're expecting. And so, that bioavailability has a very broad range. The other one that's interesting to me as well is the PO, or the sublingual, meaning oral or sublingual dosages of ketamine that are being given in multiple clinics across the country, that the bioavailability is only 16 to 20%, also highly variable. And even those places are showing that they do have some positive effects from giving people ketamine. So I think that speaks to the profound effects of ketamine. So what are we doing? Well, in typical anesthesia practice, IV ketamine is given between 1 to 3 milligrams per kilo. IM ketamine is given between 4 to 6 milligrams per kilo. So those are the doses for an anesthetic. And so we're giving far lower doses than that in a sub-anesthetic category. So our IV dosing is about 0.5 milligrams per kilo. That's kind of the standard infusion dose that's been in the studies that have been looked at for a number of years. And those are the majority of protocols for IV ketamine that's been given across both Canada and the US. For our practice, we're actually giving intramuscular ketamine. And so we start with a low dose of 0.5 milligrams per kilo. We administer that initially, and then we see how our patients are doing. We'll top them up to 1 to 1.5 milligrams per kilo in their setting. So once they've established, we've had a dose finding and we've established that they have minimal side effects with the 0.5 milligrams per kilo, then we do advance it if they're tolerating it. Okay, so what are the systemic effects of ketamine? So obviously there are side effects, which is why we do this in a medical environment with medical supervision. So cardiovascular effects are increased heart rate and increased blood pressure. These are usually transient. As ketamine wears away from your system, those side effects go away. Very rarely in the studies, maybe 1 to 2% of patients ever required any intervention for this. So high blood pressures are well tolerated for short periods of time, especially if patients have no contraindications or reasons to why they can't have that. The other things we need to be concerned about are patients who have poor cardiac function. So patients who are highly sympathetically stimulated, like in sepsis or trauma, may not be the best candidates for ketamine because it can decrease cardiac contractility. So obviously those are not our patients, but that is an effect of ketamine. It doesn't always increase heart rate and blood pressure and improve those outcomes. From a respiratory perspective, at high doses, ketamine can induce some respiratory depression, but at the doses that we're using, very uncommon. It actually stimulates respiration, which is good. It maintains upper airway reflexes, so it's very safe because patients are in control of their own airways, even though they are somewhat sedated. It is a bronchodilator. It can increase secretions, and that's really the highest risk of respiratory complications is potential for laryngospasm from increased secretions and a sedated state. So the other systemic effects are neurologic. So dissociation is obviously the one that we're looking at the most. Now, what's interesting is that in previous studies, when they looked at intravenous ketamine, the goal was actually to not have dissociation because they found it as a negative side effect. But more current research has shown that actually dissociation is actually beneficial to the treatment of treatment-resistant depression. So although you can get an antidepressant effect of ketamine without having dissociation, you actually get more of an antidepressant effect if you have some dissociation. It is a psychotomimetic. You can have some hallucinations from it. Patients can have abnormal muscle movements, twitching, myoclonus. Most common side effects are actually dizziness, nausea, and vomiting. So about 10% of patients will have some dizziness, nausea, or vomiting. About 1% to 2% of patients that will be intractable in, and that sometimes does lead to them not continuing on with treatment, but it's extremely, extremely rare. And if you think about that compared to the side effects of SSRIs or SNRIs, you can see how much less that is. They may get some nystagmus and some double vision as well. Every patient that comes to the clinic is screened. So from a medical perspective, I ensure that they don't have any contraindications. So obviously pregnancy is a contraindication to having ketamine. Anyone with severe or poorly controlled coronary artery disease, unstable hypertension, if they have hypertension that is treated, that's not a contraindication. If they have severe sleep apnea, they're not a candidate for our clinic, as well as morbid obesity, because doing this in an outpatient setting would be slightly too risky. If they have any unstable respiratory or airway disease, meaning tracheal stenosis, tracheomalacia, have had previous airway surgery, they would not be a candidate. And then because it's metabolized by the liver, anyone with severe liver disease is not a candidate. Anyone with any intracranial masses, hydrocephalus, so elevated ICP, is not a candidate for treatment. Glaucoma is not a candidate for treatment, and if you have poorly controlled seizure disorder. And you can see anyone that has any acute psychosis is also not a candidate for treatment. What makes ketamine different and what sets ketamine apart from other traditional antidepressants or other antidepressant medications? So first of all, rapid onset. It comes on within hours. People report that they've had antidepressant effects within hours. The anti-suicidality effect comes on within hours. It has high efficacy. As we stated, about 7 in 10 patients respond to ketamine. Very minimal side effects that are very well tolerated. It has a short half-life of about 2 to 3 hours, so it's out of your system relatively quickly. It has a different mechanism or mode of action than traditional antidepressants. So patients who are on traditional antidepressants remain on their antidepressants, and then they may add ketamine. There have been studies also that have shown that adding ketamine to SSRIs and SNRIs has actually sped the onset of those other medications. So it's increased their efficacy and sped the onset of action for those. It's very well tolerated and has an excellent safety profile. It's been used for years. So the ketamine-assisted therapy clinic in the Okanagan is just recently opened. We're on to our second cohort of patients now, being done in a non-hospital certified medical surgical facility that's been accredited by the College of Physicians of BC. So we're not just doing it in some, random garage or back office or something like that. It's followed in accordance with all currently recommended BC College guidelines. The patients are screened by myself, and then they're screened by psychiatry as well if they've been referred from a GP to ensure that they're appropriate candidates for this treatment. So not everyone who comes in is appropriate, and people cannot self-refer, so they have to be referred from their medical professional. On site, all appropriate resuscitation and airway management equipment is there and available. So we have defibrillators, we have all appropriate airway intervention equipment like ambu bags, airways, endotracheal tubes, etc. is all on site. Patients are supervised by myself or another anesthesiologist when we get to that point. We have one-to-one nursing for all our patients, so they are cared for by nurses who have skills in ICU, eMERGE, ACLS, PAR. So these are highly trained, highly skilled nurses who are used to patients crumping on a regular basis. So it's really special that we have the opportunity to have those nurses looking after these patients. And our facilitator is actually a paramedic as well, so there's another set of hands that are very useful. All patients are monitored throughout the treatment, so they have blood pressure cuff, pulse oximetry monitoring continuously, and we do have the capability to do continuous cardiac monitoring if necessary. The college is working on their guidelines, so at this point this is all that's required. As that changes, we may have to change some of our monitoring capabilities, but they are all discharged home to a family member when they meet standard discharge criteria. They are advised obviously not to do anything until the next day, and they have a safe environment that they're at home with. And then they're followed up the next day with a phone call and then go on to psychotherapy. So I think what's really unique about our clinic is that we've brought experts in both fields of anesthesia, who are familiar with the medicine of ketamine. We've got experts in psychotherapy and psychiatry who are familiar with mood disorders, and we've brought them all together to kind of provide a holistic care plan for these patients, and hopefully help some people get through this time in their lives. We call ourselves a chapter in their lives. They may need future treatments with ketamine, and hopefully we're able to offer that as well. But currently we do our sessions of ketamine IM, and then they progress through the program. And that's it.